The name's thyroid. Hypothyroid. Okay, that was a terrible segue into this chapter on thyroid disease. Welp, some things you can't unhear. Sorry. This chapter will cover the various derangements that can affect that squishy little organ in your neck, the thyroid gland. All of the greatest hits will be reviewed. Hypo, hyper, we'll cover it all. By the end of this chapter, you'll never say thyroid again. Get it? Yeah, nailed it. This sketch will focus on the first of these thyroid derangements, hypothyroidism. And as you might have guessed from my amazing intro to this video, we are screening the latest installment in the adventures of everybody's favorite debonair secret agent. Hypothyroidism is a condition that most commonly results in decreased secretion of the thyroid hormones triiodothyronine, aka T3, and thyroxine, aka T4. Hypothyroidism can result from a defect anywhere in the hypothalamic pituitary thyroid axis, but the vast majority of cases are primary, meaning they're caused by a disease within the thyroid gland itself. Hypothyroidism caused by a disease higher up on the HPT axis is known as central hypothyroidism. Central hypothyroidism can be caused by diseases affecting the anterior pituitary, aka secondary hypothyroidism, or hypothalamus, aka tertiary hypothyroidism. Secondary hypothyroidism is caused by disease within the anterior pituitary, which is responsible for secreting thyroid stimulating hormone, aka TSH. To remind you that pituitary disease is the cause of secondary hypothyroidism, we've included our recurring sketchy symbol for pituitary dysfunction, the pituitary punching bag here on this poster. Tertiary hypothyroidism goes even higher up on the axis, resulting from diseases affecting the hypothalamus, which is responsible for secreting thyrotropin releasing hormone, aka TRH. At Sketchy, hypothalamic dysfunction is represented by the torn Hype press release poster advertising that boxing match. Sorry, guy, but hey, did you really expect a big response from posting a boxing ad in a hospital? Anywho, central hypothyroidism is a lot less common than primary hypothyroidism, making up only 1% of all cases of hypothyroidism overall. With that bit of introduction out of the way, let's get to the good stuff and take a look at the wide variety of clinical manifestations that patients with hypothyroidism can present with. Thyroid hormones regulate a lot of key physiological processes, including metabolism, thermogenesis, mood, and even GI motility. So it shouldn't be surprising that hypothyroidism results in many of those processes being slowed down. Perhaps the most common presenting symptom of hypothyroidism is fatigue, represented by this super tired patient in her hospital bed. Additionally, many patients with hypothyroidism experience weight gain, usually in the range of 10 to 30 pounds due to slowing of their basal metabolic rate. Ooh, watch out for that falling cup of ice. It represents cold intolerance, which is a classic symptom. Cold intolerance in patients with hypothyroidism is caused by decreased thermogenesis. Hypothyroidism also results in decreased GI motility, making constipation a common complaint. Hence our recurring sketchy symbol for constipation, the plunger in this patient's bathroom. See that eerie brain-shaped hairnet on her head? Aside from being the latest in hospital fashion, it also represents cognitive impairment, a common feature of hypothyroidism. Cognitive impairment in hypothyroidism typically manifests as slow mentation, decreased concentration, or poor working memory, and can be more apparent in elderly patients. Therefore, when an elderly patient presents with cognitive impairment, make sure to rule out hypothyroidism before you call it dementia. Remember, unlike dementia, cognitive impairment rarely occurs in isolation in patients with hypothyroidism. Along those same lines, make sure to check for hypothyroidism in patients who present with depressive symptoms. Depressed mood in hypothyroidism, represented by that sad face circle on the wall, is reversible if the underlying hypothyroidism is treated, making it an important condition to rule out before a diagnosis of major depressive disorder is made. We're not done yet. Break out the lotion and leave-in conditioner. Because while they may not be their chief concerns, patients with hypothyroidism often complain of dry, rough skin and coarse, brittle hair. These changes occur as a result of the accumulation of matrix glycosaminoglycans in the interstitial spaces of skin and hair. And those wrist braces she's wearing? They're here to remind you that hypothyroidism is commonly associated with bilateral carpal tunnel syndrome. Carpal tunnel syndrome in hypothyroidism is believed to be due to mucin deposition within the carpal tunnel, increasing pressure on the median nerve and leading to the classic symptoms of numbness, tingling, and pain in the first 3 fingers and half of the 4th finger. It's not just the nerves that can be messed up. Muscle involvement, also known as hypothyroid myopathy, is also common in adults with hypothyroidism. Hypothyroid myopathy typically manifests as progressive symmetric proximal muscle pain and weakness, represented by this patient's weak arm laboring to use her TV remote. The struggle is real. And last but not least, see those red spots on our bedsheet? They represent abnormal menstruation. Women with hypothyroidism can have a wide variety of menstrual abnormalities, ranging from oligo or amenorrhea to menorrhagia. These menstrual changes result in decreased fertility. Now, when your patient has primary hypothyroidism, you should only expect symptoms related to impaired thyroid function, like the ones we just reviewed. In central hypothyroidism, however, other symptoms of hypopituitarism are often seen as well. These can include hypogonadism and adrenal insufficiency, which we'll cover in separate sketches later on in this unit. Now that you know what patients with hypothyroidism present with, let's talk about why they're hypothyroid. Let's begin by introducing the main villain, Dr. Hashimoto. Dr. H and his untied red bow tie represent the most common cause of hypothyroidism in iodine sufficient areas of the world, Hashimoto's, aka chronic autoimmune, thyroiditis. That's why Dr. H is holding up one finger, BT dubs. Since Hashimoto's thyroiditis is also known as chronic autoimmune thyroiditis, it shouldn't surprise you to learn that the disease is caused by autoimmune mediated lymphocytic destruction of the thyroid gland. At Sketchy, autoimmune disease is represented by a recurring symbol, the antibody shape, this time in the form of Dr. H's prosthetic hand. Chronic autoimmune thyroiditis most commonly occurs in women, especially older women, which is why Dr. H's hostage is an older woman. See those spare antibody tools sticking out of Dr. H's doctor bag? They represent the other autoimmune diseases that are more common in patients with chronic autoimmune thyroiditis. A personal or family history of conditions such as type 1 diabetes, adrenal insufficiency, pernicious anemia, and vitiligo is a risk factor for Hashimoto's. One last funky thing about chronic autoimmune thyroiditis before we go. While hypothyroidism is the classic presentation associated with chronic autoimmune thyroiditis, early on in the course of the disease, patients may actually have transient hyperthyroidism. Hence the stretched red bow tie around this older woman hostage's neck, looking like it's about to break. Transient hyperthyroidism in Hashimoto's is thought to be caused by rupture of the thyroid follicles and subsequent release of the thyroid hormone stored inside. We'll come back to Dr. Hashimoto and his evil plan a little later. For now, let's talk about the most common cause of hypothyroidism in non-iodine sufficient parts of the world. Well, we kind of gave it away, but as this poster indicates, iodine deficiency is the most common cause of hypothyroidism worldwide. Even then, hypothyroidism from pure iodine deficiency is pretty rare. The reason you won't see iodine deficiency very often in developed countries is because iodine is a common addition to table salt, ensuring that most people get enough of it through their diet. After chronic autoimmune thyroiditis and iodine deficiency, the next most common cause of hypothyroidism is actually our fault. Yep, I'm talking about iatrogenic hypothyroidism. The most straightforward way we as physicians cause hypothyroidism is, well, by removing the thyroid. Total and often subtotal thyroidectomy typically result in hypothyroidism. At Sketchy, surgery is represented by our recurring symbol, the surgery scalpel. It's important to note that not all types of thyroid surgery result in hypothyroidism. Partial thyroidectomy typically doesn't remove enough tissue to cause hypothyroidism. Radioiodine therapy can also cause hypothyroidism. Ironically, radioiodine therapy is typically performed for hyperthyroidism, but it often leads to hypothyroidism due to destruction of thyroid follicular cells. Finally, external irradiation of the neck can also cause hypothyroidism. It usually takes high doses to do so we're not talking about a random X-ray or CT here or there. This is more along the lines of radiation therapy for Hodgkin lymphoma, head or neck cancer, or even survivors of nuclear accidents such as Chernobyl or Hiroshima. At Sketchy, radiation therapy is represented by a recurring symbol, the radiation symbol illuminating the patient's neck. Hope you've got your lead on. Or you're hiding behind a ficus? Hey, if it works. Anywho, a thyroid-shaped fibrous ficus is our Sketchy symbol for Riedell's thyroiditis, also known as fibrous thyroiditis, a rare infiltrative thyroid disease characterized by fibrosis of the thyroid gland that extends to the surrounding soft tissue. Approximately 1/3 of patients with Riedell's will have hypothyroidism as functional thyroid tissue is replaced with fibrous junk. So far, most of the conditions we've talked about cause permanent hypothyroidism, but not everything lasts forever. What? It's a good thing in this case. Certain types of inflammatory thyroid diseases can cause transient hypothyroidism. In these conditions, inflammation initially results in lysis of the thyroid follicular cells and hyperthyroidism, hence the peak in the sine wave monitor. After a few weeks, these thyroid hormones become depleted, leading to hypothyroidism and the trough in that wave. In most of these cases, though, thyroid function returns to baseline within a year, just like how the sine wave ends up where it started. What do you say? Let's take a look at a few of the most common causes of transient hypothyroidism. The first and most well known cause of transient hypothyroidism is subacute, aka de Quervain's thyroiditis. Subacute thyroiditis is presumed to be caused by a post viral inflammatory process, so look for patients who present with a painful thyroid gland 2 to 8 weeks after a recent viral upper respiratory infection. While subacute thyroiditis causes a painful thyroid gland, silent thyroiditis is another cause of transient hypothyroidism that presents without thyroid pain. That's why they call it silent, and why this nurse is shushing the baby she's holding. Silent thyroiditis is a variant of chronic autoimmune thyroiditis that presents with initial hyperthyroidism that is sometimes followed by hypothyroidism. We'll talk about silent thyroiditis a bit more in our next sketch on hyperthyroidism, so stay tuned. The baby that nurse is holding isn't just for fun. It represents postpartum thyroiditis, the third and final cause of transient hypothyroidism you should be aware of. Postpartum thyroiditis is very similar to silent thyroiditis, except that by definition, patients need to be women presenting with symptoms within 1 year of giving birth. Before we move over to the physical exam and workup of hypothyroidism, there's one last group of etiologies to discuss: medications. As you might imagine, there are a bunch of different drugs that can mess with thyroid function. We'll just cover two of the most well known drugs here: amiodarone and lithium. Amiodarone, represented by our recurring sketchy symbol, the amiodarone amigo here in bobblehead form, is an interesting drug in that it can cause hypo or hyperthyroidism. So watch for our little friend to make another cameo in our next sketch on hyperthyroidism. Amiodarone is thought to cause hypothyroidism primarily by inhibiting peripheral conversion of T4 to T3 in tissues. Lithium, on the other hand, can cause hypothyroidism by inhibiting the release of T4 and T3 by the thyroid. At Sketchy, our recurring symbol for lithium is the lithium lift. If only it lifted thyroid hormones too. Welp, hope springs eternal. Alright, it's time to move on to the objective findings seen in hypothyroidism. First things first, take a look at your patient's vitals. Because, vital signs are vital. Bradycardia, represented by our recurring sketchy symbol, the broken heart shaped watch, is a frequent finding in patients with hypothyroidism. The mechanism behind this finding in hypothyroidism is still unknown, but it's thought to be due to decreased expression of beta adrenergic receptors on the heart. One counterintuitive finding you might see in patients with hypothyroidism is hypertension. Represented by our recurring sketchy symbol, the steam coming out of this doctor hostage's ears. I'd be upset too if I were tied up and forced to stay at work past my shift. The hypertension in hypothyroidism is primarily diastolic due to increased systemic vascular resistance, which is why this hostage is wearing our recurring sketchy symbol, the diastolic diamond earrings. Dang, they went the whole 9 yards tying that hostage up. No wonder she's so upset. Anyways, the extra thick blue lead apron she's wearing and her puffy face represent myxedema, which can be seen in patients with severe hypothyroidism. Myxedema is a non-pitting edema that can occur in any part of the skin and is caused by accumulation of glycosaminoglycans with associated water retention. Keep that word in the back of your head, because there's one more feature of myxedema that we'll cover later on in this sketch. On neuroexam, patients with hypothyroidism may have reduction or outright loss of deep tendon reflexes, represented by that tied up doctor's fallen reflex hammer lying on the floor. The one thing she needed to get her out of her bind. Get it? Bind? No. Hilarious. At this point, you might be wondering, what about goiters? I mean, that's what hypothyroidism is all about, right? Well, yep, you'd be right. Kinda. Goiter is seen only in patients with primary hypothyroidism since they form as a result of excess TSH secretion by the anterior pituitary in a futile attempt to stimulate thyroid growth. More on that in a moment. Different causes of hypothyroidism produce different types of goiter, which can be helpful in distinguishing one etiology from another. Let's break down the different types of goiter associated with the most common causes of hypothyroidism. One big difference among the different types of goiter is whether or not they're tender. Let's start with the causes of non-tender goiter first, since they're the most common. See that pulled down face mask on Dr. Hashimoto's neck? That represents the non tender, symmetrically enlarged goiter seen in chronic autoimmune thyroiditis. Moving on to the most common cause of goiter worldwide. In iodine deficiency, the goiter is also non tender. While the goiter may be initially diffuse, adults with long standing iodine deficiency eventually develop nodular goiter, represented by the nodular necklace worn on that patient's neck, because the cells in some thyroid follicles proliferate more than others. Finally, remember our fibrous thyroid ficus? Well, the knot in this tree branch, conveniently located in front of our hiding guy's neck, represents the stony, hard goiter seen in Riedl's thyroiditis. Like Hashimoto's and iodine deficiency, the goiter in patients with Riedl's is also non tender. Those are your non tender goiters. If your patient has a tender goiter, well, your day just got a lot easier, buddy. Thanks to our debonair protagonist rushing in to save the day. But also because there's only one cause of hypothyroidism associated with a tender goiter. See how he's punching this bodyguard square in the neck? First of all, awesome. But more importantly, that baddie's painful neck represents the exquisitely tender, symmetrically enlarged goiter seen in subacute thyroiditis. Even though some of the symptoms and signs we've discussed are pretty specific for hypothyroidism, the primary way we diagnose hypothyroidism is through lab testing. Fortunately, the diagnostic algorithm for hypothyroidism is pretty straightforward. In most patients with symptoms or signs suggestive of hypothyroidism, a serum thyroid stimulating hormone level should be the initial test. That's because an elevated TSH, represented by this baddie's tight red bow tie, is the most sensitive indicator of primary hypothyroidism, which accounts for more than 95% of cases of hypothyroidism. TSH is elevated, typically greater than 5 microunits per milliliter, in primary hypothyroidism because the primary derangement is low thyroid hormone levels. Therefore, due to negative feedback inhibition, the pituitary ramps up TSH production in a futile attempt to stimulate the thyroid into producing more hormone. Most labs, including your hospital or clinics, may run what's known as a TSH with reflex free T4, meaning that if the TSH is elevated, the lab will then run a thyroxine level to determine if overt primary hypothyroidism is present. A low serum free T4 level establishes the diagnosis of hypothyroidism. At Sketchy, the free T4 level is represented by the time bomb set to 4 minutes, falling to represent a low free T4 level. So why do we specify free? It's definitely not because of the cost. The free T4 level measures the unbound portion of T4, which is metabolically active. This is in contrast to total T4 levels, which measure both free T4 as well as T4 that's bound to thyroid binding globulin. As you can imagine, a normal total T4 level doesn't necessarily preclude hypothyroidism. A well-known example is pregnancy, in which TBG levels are elevated. As a result, hypothyroidism in pregnancy can be missed if you only measure a total and not the free T4 level. Alright, so high TSH and low free T4 equals primary hypothyroidism. Got it. Then why does this dude have another time bomb tucked in his waist? How many time bombs does one guy need? That non-falling time bomb represents a normal free T4 level, which can be seen in patients with an elevated TSH. A normal free T4 level in the setting of an elevated TSH indicates subclinical primary hypothyroidism. As its name suggests, most patients with subclinical hypothyroidism are completely asymptomatic. Consequently, subclinical hypothyroidism can only be diagnosed on labs. Getting an initial TSH with the reflex-free T4 is the way we diagnose primary hypothyroidism, which, as we've mentioned, comprises the vast majority of cases of hypothyroidism. If you suspect your patient may have central hypothyroidism, however, you gotta get both labs. Central hypothyroidism should be suspected if your patient has known hypothalamic or pituitary disease or presents with symptoms or signs of other hormonal deficiencies in addition to hypothyroidism. In patients with suspected central hypothyroidism, the serum free T4 level should be low, natch, which is why this 4-minute time bomb is sitting on the floor. What clinches the diagnosis, though, is a serum TSH level that is not appropriately elevated given the low free T4. That's why this henchman is tying his tight red bow tie near the floor in that air vent. What an odd job he is. Has. Please don't sue us, MGM. Classically, like on exams, you'll see a low TSH in central hypothyroidism, but a normal TSH in the setting of a low free T4 should raise red flags as well. We call this an inappropriately normal TSH level. Once you've made the diagnosis of central hypothyroidism, the next step is to distinguish between secondary and tertiary hypothyroidism. But we don't do that with labs. Instead, if patients have laboratory evidence of central hypothyroidism, the next step is to order a brain MRI to evaluate the hypothalamus and pituitary for disease. Let's finish up our discussion with a few lab abnormalities that are also frequently seen in patients with hypothyroidism. Sometimes, patients with hypothyroidism will present primarily with symptoms of muscle weakness and pain. These patients with hypothyroid myopathy will also have an elevated serum creatinine kinase level, represented by that bucket of CK crispy chicken on the patient's tray. Since hypothyroid myopathy is not an inflammatory condition, markers of inflammation, such as ESR, will be normal. That's one way you can differentiate other causes of muscle pain and weakness, like polymyositis, from hypothyroid myopathy. Don't forget to get a lipid panel. Patients with hypothyroidism often present with hyperlipidemia with high serum LDL levels due to downregulation of surface LDL receptors. It typically normalizes with treatment of hypothyroidism. At Sketchy, hyperlipidemia is represented by the stick of butter on the patient's hospital tray. Fried chicken and butter. Don't you love hospital cafeterias? Lastly, see that antibody shaped gun sitting next to a transport briefcase? Those are our recurring Sketchy symbols for antithyroid peroxidase antibodies. Anti-TPO antibodies are positive in the vast majority of patients with chronic autoimmune thyroiditis. So, you'd think we'd order them to confirm the diagnosis of Hashimoto's in a patient with lab evidence of primary hypothyroidism. Well, you'd be wrong. Anti-TPO antibodies are not routinely ordered in patients who already have documented primary hypothyroidism because virtually all of them have chronic autoimmune thyroiditis. So it'd be telling us something we already know. That's how common Hashimoto's is in iodine sufficient countries. Let's summarize the clinical presentation of hypothyroidism in a sample assessment statement. Miss Trench is a 39-year-old previously healthy woman presenting with progressive fatigue, weight gain, muscle weakness, and menstrual irregularities over the past 3 months. Physical exam is significant for a non-tender enlarged thyroid and diminished knee and ankle jerk reflexes. Labs are significant for elevated TSH, decreased free T4, and elevated CK. Miss Trench's constellation of symptoms, in conjunction with her thyroid function studies, are consistent with primary hypothyroidism, most likely secondary to chronic autoimmune thyroiditis. So, you've diagnosed your patient with hypothyroidism. The hard part is over. Fortunately, treatment of hypothyroidism is pretty straightforward. The treatment of choice for hypothyroidism is levothyroxine, or synthetic T4, represented by the synthetic T4 explosive on Dr. Hashimoto. Clinically, you'll want to monitor TSH levels regularly and titrate the patient's levothyroxine dose to keep TSH in the normal range. Unfortunately, most patients with hypothyroidism will require thyroid hormone replacement for the rest of their lives because the vast majority of causes of hypothyroidism are permanent. The exception to this rule, there's always one, is transient hypothyroidism. The causes of transient hypothyroidism usually resolve on their own within several weeks. So, if these patients have significant hypothyroid symptoms, most don't, they're only treated with levothyroxine for a few months at most. Speaking of exceptions, let's take a quick detour and talk about the management of a few special cases. Most patients with subclinical hypothyroidism don't need to be treated. However, experts recommend thyroid hormone replacement for patients with serum TSH levels greater than 10 microunits per milliliter. That's why this hostage wearing that T4 explosive is holding up 10 fingers. Don't worry, dude. It's for your own good. Finally, there's a subset of patients with hypothyroidism who need a little bit more love. And by love, I mean levothyroxine. One and the same, am I right? I'm referring to women in states of elevated estrogen, such as pregnancy. As we alluded to earlier, that's because estrogen decreases clearance of thyroxine binding globulin, TBG, leading to increased TBG levels. More TBG binding to T4 means less free T4 and, therefore, worsening of hypothyroidism. That's why this pregnant hostage has extra 4-minute time bombs bound to her pregnant belly. Not cool, terrorists. Not cool. Anywho, pregnant women with hypothyroidism will require higher doses of levothyroxine during pregnancy. As always, titrate the dose to keep the TSH levels in the normal range. Similarly, women with hypothyroidism who also take estrogen-containing oral contraceptives will also require higher doses of levothyroxine. So make sure to ask about OCP use, represented by our recurring Sketchy symbol, the OCP-shaped timer on that woman's leg. That about does it for the basics of hypothyroidism. For the rest of this sketch, We'll briefly review a couple of unique cases of hypothyroidism that you might not see on the wards, but will probably be tested on. The first is a complication of hypothyroidism that we don't typically see anymore: myxedema coma. Myxedema coma is a severe complication of hypothyroidism that's characterized by decreased mental status, hypothermia, and other symptoms of slowed organ function. As you might expect, myxedema coma is a medical emergency. Myxedema coma typically occurs as the result of years of severe, long-standing hypothyroidism, represented by that line of yearbooks down there, or precipitated by an acute event, such as infection, MI, or high doses of opioids in a patient with poorly controlled hypothyroidism. As mentioned earlier, the classic presentation of myxedema coma is decreased mental status, usually confusion and obtundation rather than coma itself, represented by a recurring brain-shaped hairnet that's fallen off the doctor's head. The other hallmark of myxedema coma is hypothermia, represented by this open freezer unit, which occurs due to decreased thermogenesis. Other, less specific signs include hyponatremia and hypoglycemia, among others. Remember, hypothyroidism is all about slowing of metabolic processes. Myxedema coma is a true medical emergency and needs to be treated right away. So, what do you do? Fortunately, since it's just a manifestation of severe hypothyroidism, the management of myxedema coma is similar to that of run-of-the-mill hypothyroidism. That means thyroid hormone replacement is still the foundation of treatment. However, patients with myxedema coma should be given thyroid hormone via IV, reflecting the severity of the condition. That's why this T4 explosive is covered in our recurring sketchy IV. In addition, though, patients with myxedema coma should also be given IV glucocorticoids, represented by our recurring sketchy symbol, the moon-faced planter. This is because adrenal insufficiency is often a comorbid condition in patients with severe, long-standing hypothyroidism. Severe adrenal insufficiency can also present in similar ways as myxedema coma, so until you rule it out, you give them both thyroid hormone and steroids. Finally, let's end with a condition that is seen quite frequently in ICUs everywhere: euthyroid sick syndrome. Euthyroid sick syndrome is a pattern of abnormal thyroid function test results seen in many patients with severe illnesses, like those in the ICU. To help you remember that euthyroid sick syndrome typically occurs in the ICU, we've highlighted the U in this ICU sign. The most common pattern seen in euthyroid sick syndrome is a low T3, represented by that falling 359 time bomb, normal T4, and normal TSH. The low serum T3 levels are caused by decreased peripheral conversion of T4 to T3, which may actually be a protective evolutionary response to severe illness, as it prevents excessive tissue catabolism. Importantly, patients with euthyroid sick syndrome should not receive thyroid hormone replacement. Studies have shown no benefit in doing so, and the lab abnormalities typically correct once patients recover from the acute illness. Alright, let's wrap up this sketch with a brief summary of what we've learned about hypothyroidism. Primary hypothyroidism, in which the thyroid gland itself is the source of the dysfunction, comprises the vast majority of cases. Much less commonly, the cause is hypothalamic or pituitary disease, also known as central hypothyroidism. The most common cause of hypothyroidism in iodine-sufficient countries is chronic autoimmune thyroiditis. In other parts of the world, iodine deficiency is the most common cause. Those are the big two. Other, less common etiologies of hypothyroidism include iatrogenic causes, such as thyroidectomy, radioiodine therapy and external neck radiation, medications such as amiodarone and lithium, and causes of transient hypothyroidism, such as subacute thyroiditis, painless, and postpartum thyroiditis. Clinically, hypothyroidism results in the slowing of metabolic processes throughout the body, manifesting as fatigue, weight gain, cold intolerance, constipation, cognitive impairment, and depression. In addition, symptoms such as dry skin, brittle hair, bilateral carpal tunnel syndrome, hypothyroid myopathy, and reproductive abnormalities are also commonly seen. On exam, look for myxedema, delayed reflexes, and varying degrees of thyroid enlargement, aka goiter. A non-tender goiter is classically present in chronic autoimmune thyroiditis and iodine deficiency, whereas subacute thyroiditis typically produces an exquisitely tender goiter. To diagnose hypothyroidism, start with a TSH. Elevated TSH should lead you to order a reflex-free T4. A low free T4 cinches the diagnosis of primary hypothyroidism. A normal free T4 in the setting of elevated TSH indicates subclinical hypothyroidism. On the other hand, a low free T4 in the setting of a TSH that's not appropriately elevated should raise red flags for central hypothyroidism. Hypothyroidism is also associated with a number of other lab findings, such as elevated creatinine kinase and hyperlipidemia. The management of hypothyroidism is pretty straightforward. Levothyroxine is the treatment of choice in basically all forms of hypothyroidism. Notably, women in elevated estrogen states, such as pregnancy or if taking OCPs, require higher doses of levothyroxine. Myxedema coma is a severe complication of long standing hypothyroidism that isn't seen much anymore, but is a medical emergency. It's characterized by decreased mental status and hypothermia. Thyroid hormone replacement is still the name of the game here. But we usually treat these patients via IV and give glucocorticoids as well to cover the possibility of adrenal insufficiency. Finally, euthyroid sick syndrome is a pattern of abnormal thyroid function test results that's commonly seen in super sick patients admitted to the ICU. It's characterized by a low T3 level with normal T4 and TSH levels due to decreased peripheral conversion of T4 to T3. Thyroid hormone replacement is not recommended for patients with euthyroid sick syndrome since it doesn't work. Their thyroid function labs will return to normal after they recover from their acute illness. Whew! Pat yourself on the back and break out some Bollinger, because you've just conquered hypothyroidism. Now let's never say hypo or thyroid again.